Great. So a lot of what I'm talking about in terms of prepare, if any of you were at the plenary session, some of it will be just a reminder about that. But really thankful, Bud and Stephanie sort of asked me here to this session so that I actually can get advice from you all in the audience about ways that prepare and respecting choices could potentially collaborate. And we've been talking about that for years. We've thought about getting grant funding for it for years. And you know, some of this may start sort of organically, but maybe some of you are already doing it or thinking about it, and so would really like to get your input. So I think in terms of that, I'll just, again, sort of step back a little bit and talk about how we created our program and why we created it. You know, and I think when we were thinking about this and thinking about tough decisions that people had to make, you know, you and my family members and I, you know, you would hope for that you would have sort of the 800 facilitators, which is amazing, that Stephanie has trained to have these conversations, you know, that can communicate compassionately, but also I think realizing again from my patients and my family members that there's sort of this lack of a framework to fall back on when something sort of happens. And so you also hope you have these people to help you, but that you might be able to have a framework to identify sort of what's important to you, to be able to speak up about that and advocate for your loved ones and talk to your medical providers to get that. And I would say throughout the course of my clinical and research career, there just really are massive communication breakdown. And again, why are we all here? Why are we training facilitators? I think that is why. And I would say for a lot of the disenfranchised patient populations that I work with, there is a huge amount of lack of empowerment and mistrust. Surrogates are not empowered to speak up for other folks or to even have these conversations. And so I think part of that being lack of empowered comes back a little bit to health literacy. So I just wanted to touch on this a little bit because I think it is so important when we're thinking about the patient populations. You know, this cartoon says, you don't call this a legal document, do you? I can understand every word of it. And, you know, this was the advanced directive that was being used at our county hospital. And if you can't read anything on it, most other people couldn't because it was written at 8-point font. It is written, still available at 8-point font, and really difficult to understand. And I was on the ethics committee at San Francisco General Hospital, and we were finding that up to 15% of our ICU patients were ending up in the ICU with no one to help make medical decisions for them, nothing in the medical record, nobody knew what to do for them. They were on ventilators for months. And they had very low advanced care planning documentation rates. And again, I think when we go back to the patient and we think about what the flow should be for advanced care planning, how does this work, right? The clinician would initiate a conversation or facilitator and give materials. The patient, you know, hopefully asks questions, identifies their wishes, discusses their wishes with the surrogate and the doctor, documents, has full understanding, and a clinician will place this into the medical record. And all of those things, most of those things are patient tasks. And most of those tasks can be affected by literacy, culture, and language. And so for people who don't know, the formal definition of health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. And you may not know also that the mean reading level in the US is only at the 8th grade level. And for older adults, it's only at the 5th grade reading level. And then we think about, actually they've done studies to show that most of the health information that we give to people is at the 12th grade or actually higher, postgraduate reading level. And then when you think about this definition, the ability to obtain, process, and understand health information, you know, you could be a rocket scientist, but then you lay a motion of a new diagnosis on that and everything just sort of goes out the window. So there's only so much that people sort of can take in. And I really think that there are huge language considerations that we have to take into account. So 60 million people in the US, about 20%, speak a language other than English at home. So 40 million are Spanish speakers, 3.4 million are Chinese speakers, and there really has been a lack of what I call linguistically appropriate materials to actually meet those patients' needs. And then we were talking a little bit about these cultural considerations. Many cultures have non-Western views on autonomy and decision-making. So in our studies in San Francisco, 20% of patients will report that they will not make their own medical decisions. So if you're not going to make your own medical decisions and you want somebody else to do it for you, how do you get people engaged in advanced care planning? And then, as I was saying before, just a lot of mistrust and experienced true racism in the medical environment, and how does that play into sort of then thinking about advanced care planning and people thinking that we're trying to withdraw support and care to them. And when we think about advanced directives, it's really high stakes. So Night of the Living Will, this is a great cartoon that's been around for about 30 years, and it's still true. And I think this idea, again, about health literacy is that checkbox responses can really have sort of life or death consequences. So again, this crazy advanced directive, there's like arcane language, I won't get into it. But even when we think about the POLST, and this is something that a clinician is sort of filling out, we've asked people sort of after it's been filled out, what does this mean? And if somebody, say, picked selective treatment, this person said, so they had said that they didn't want to be resuscitated, and then they picked selective treatment. And then when asked what that meant, it said, I only want to be on machines for a few days. My family knows this. But that was completely not what the POLST was saying, but that's what they thought that it said. And Susan Hickman, who's here in the back, hi Susan, has done studies showing that 50% sort of understood that section and about 30% were discordant with goals. So again, sort of the onus is on us to really help patients understand this information. And there's a quote from one of our focus groups that I like to read about this. It said, my mom passed away and she had signed the paper in the hospital, but it was totally wrong because she didn't really understand it. We had another one filled out, and that one said, do you want to be resuscitated? Do you want to be on a machine or not? And she said no, and then the questions were in conflict. One said yes, one said no. That really confused us. She got really frustrated, and she didn't want to talk about it anymore. And I'm sure many of you have probably had a similar experience. So just as a reminder, this sort of all culminated in us trying to think about how could we incorporate the tenets of health literacy and informed consent into the advanced directive process. And as I was talking about this morning, created this easy-to-read advanced directive. But then the question is, well, if you got this easy-to-read advanced directive and we showed that it worked in a randomized trial, like why go any further? And again, I think throughout the whole process of the development of these tools, most of the reasons for what we've done and what we've included all come from patients and their families. And so this was a quote from a surrogate decision maker that said, we got the DNR in writing, but in making the decisions, which there were many, that was just one. Because the first decision was to put him in a nursing home. We were married 30 years and I could no longer take care of him. Then the second decision was whether to put him on a feeding tube because he had stopped eating and I wasn't ready to let him go. And so this idea that yes, there's the checkbox, CPR, mechanical ventilation, but what about all the other decisions that surrogate decision makers are trying to make, that clinicians are trying to help families make, and we don't know any information about the person and their values in their life and how they would want to live. And so thinking about and talking again to patients and families, what is this missing puzzle piece? We've got some pieces, but how does it all fit together? And it really sort of came back to preparing people with skills. So skills that they can identify what's important to them, they can talk to their family and friends, they can talk to their medical providers, they can make informed choices, they can get the care that's right for them, and their surrogates can have these skills to sort of speak up for them. And so, again, that brings us back to the Prepare website and why we sort of set it up the way that we did with sort of the 5-step process. And again, this is also in Spanish. I will tell you, we're a, like to say, bubblegum and toothpick operation. And what I really wanted to do was reshoot all of our videos in Spanish, but we didn't have enough money. So we can talk, if people are interested, a little bit more about the translation, which was a huge undertaking, included translation and back translation and input from people from 5 to 6 different Spanish-speaking countries, because Again, it's not all the same, and all the cultural adaptation pieces are not the same. The words are not the same. And we wound up doing, or audio dubbing for the Spanish. But in terms of prepare, again, as I said this morning, there's 5 steps of prepare. It was never meant for people to do all 5 steps. It was meant for people to pick and choose sort of what made sense for them, or to walk through it step by step. People can save their information on the website, so if they want to do step 1 and come back. And I talked a little bit about this morning too, in terms of creating prepare and making sure that it was at the 5th grade reading level so that we could attend to that health literacy piece. There's voiceovers and closed captioning. And again, as we talked about, sort of having that range of stories. It was really interesting. What I don't have up here is in terms of the range of stories, we really tried to go out of our way to balance stories about people that wanted aggressive treatment and stories about people who wanted less aggressive treatment. And the thing that was so interesting to us is that people who wanted less aggressive treatment, they were fine if they saw a picture or story about somebody else who wanted more aggressive treatment, but the reverse was not true. So people who were scared or frightened or wanted really aggressive care for themselves were very threatened by other types of stories. And so we learned early on that we really had to kind of balance. We had to balance content and people who had surrogates and who didn't. We had to balance content and people who wanted to make decisions and not, and the different stories. And we've talked a little bit about some of these videos that model behavior, how to ask a decision maker, talk with family and friends, how do you ask clinicians questions, and that this gets printed up sort of in a summary of my wishes. I think this next slide is yours. And so, do you want to talk about this? So we were talking about this. Prepare was definitely meant as something that could help people jumpstart these conversations, to start early, to not freak them out, to be in a way that people can understand them. And we were thinking, okay, well, how does that translate into the Respecting Choices model?
Right. So many of you are familiar in the room with our stages of planning slide. This is a trajectory of chronic illness. Over 80% of Americans will develop chronic illness at some point. And we have first steps for basic advanced care planning. And then first steps is appropriate for any individual who hasn't planned. And then we have ongoing advanced care planning as people develop chronic illness, and it is advancing to advanced steps, which used to be called last steps. And that was what Stephanie was just talking about, the program that they're using. We use the POLST paradigm program for these folks. And the next steps are those that are advancing in their illness, increasingly having complications, but not appropriate for POLST conversations. So I put this slide in here because I'd like for you to start thinking now about questions that we're going to ask about, it prepares a wonderful product, and for some people will be all that they need. But for some folks, we know, would like more support, whether that's a group conversation or whether it's individual conversations. So could prepare be used to prep people in a different way for first, next, or advanced steps? I don't want you guys just thinking about using prepare for first steps or basic advanced care planning. As you're thinking about, we'll be asking you questions about how we could integrate these, what synergies there are, where there are misalignments that we should be aware of. So just be thinking of that as we move forward. And then I forgot, I had the shared decision-making in serious illness. We'll just skip through that.
Oh, great. Yeah. Well, I think for us too, and when I often give this talk, and I think about first steps, next steps, and last steps, I think about first steps, as you were sort of alluding to, Stephanie, that it's not just their life trajectory, but their readiness. So we all know those people who have stage 4 cancer and a new diagnosis who are so not ready to have those conversations. And so I think about it, in both in those ways. So I'm going to skip very quickly through some of the other stuff which you heard this morning, which was about our trial. We've talked about this already, that by providing these materials, Prepare and the Easy to Read Advanced Directive, we were able to increase the advanced care planning documentation rate to 25% and 35%, and that was in a VA trial. And then when we replicated this among about 1,000 English and Spanish-speaking patients at our county hospital, also able to get very high documentation rates, as well as increase in behavior change in discussions with surrogate decision makers and clinicians. So Let me just skip through some of these things. We talked a little bit sort of this morning about some of the updates, and I think we have time for me to maybe even just go to the website to show sort of people where they are. So maybe I'll... Does that work? Okay, great. So if you come to the face page of Prepare and you scroll down here, this is where we have sort of all these free materials that you can download. So for example, we have our Prepare pamphlet, and as I said this morning, it's sort of like the Cliff Notes of Prepare, and it's what I use when I'm in clinic to hand out to my patients. Something that I can walk through the 5 steps, and people will say, oh yeah, I've done that, but I haven't done this yet. And then I can say, okay, well, go do step 2 then. Why don't you do step 2 and come back and sort of talk to me about it. And so that's how we found that to be really helpful. In terms of the advanced directives, if you click on here, you can put in your state. So I put in California. You can see that they're sort of in English and Spanish. We have older forms. We're trying to get additional funding to update these older forms that are already in these other languages, but then you can, you know, if you clicked on Spanish.
And I'll just pipe in about that. I mean, it's incredible that they've done this amazing work for every state, right? And on the flip side of that, we know that language alignment is so important to reduce confusion. And so that's one of the other things that we've talked about and are interested in. We don't have resources, we don't have funding to do it, but better aligning the respecting choices language with the prepare language, what would that look like? How big of a project is that going to be? That's something I'd also like your opinion on, if you think that's important enough to go through that extensive work that it may require. We don't know. We haven't done an analysis. We haven't evaluated it. But something to be thinking about as well that we'll get back to.
Yeah. And I would say, just to put in a plug for anybody who's interested, there have been health systems who have contacted us wanting other languages. And that's a way that we can partner with them, because if they have funding for the translation, then we can make them available sort of for everyone. Mm-hmm. So something to think about if there's a particular language that you're interested in. Let me go back here to the home page. So just some other things to draw your eye to. So this is the Prepare movie, and then these are the Prepare movie toolkits for movie events. And I think we talked about this morning that we've been doing a lot of piloting you know, in libraries, churches, and senior centers. Do you guys know about the Reimagine campaigns that are going on? Sort of it started to sort of be aligned with National Healthcare Decisions Day, but there's they had Reimagine, which was sort of a whole San Francisco citywide program to try to get different people thinking about this. The, you know, college system, the financial system, you know, theater, churches, again, libraries, senior centers, people sort of thinking about this. There were dance events, all these things thinking about, you know, end-of-life care and advanced care planning. And we piloted using this in libraries. Again, we put together these toolkits so that anyone could just pick up and start use them. So if you go to the website, I don't know if we have time, but there's actually, if I go here to get the toolkit, we do want you to put your information in just so that we know who's using the toolkit, but there's a whole video here about how to put on an event. So how do you use the toolkit? How do you use Prepare? Where do you click play? How does it work? It's all there. And again, it was really set up for librarians. Like, think about a librarian who's never done advanced care planning. And if a librarian can do it, you could imagine that we also want this to be used in clinical care. Maybe it's not by a physician or a nurse, but even other staff members could hopefully be able to use this. And then in terms of the movie, if you're interested, you can basically come here to any of the steps. You can watch the full movie from start to finish. But I would say in group medical visits, if you're interested, the way that we've done this is oftentimes either in one setting where we will play the welcome, step 1 and step 2. And then for people who are interested and want to come back, we'll do sort of 3, 4, and 5 in a separate group. But that usually seems to work well. All right, so let me go back here. Yes. Let me scroll down here. Okay. All right, so then here are some questions for you. And do you want to take this part?
Yeah.
Okay.
Yeah, I will. So I'm going to repeat your questions so that way we don't have to run around, or your comments, run around the room with microphones. So a couple of the questions you see up here, thinking about the synergies, and we know you haven't delved deep enough to get really in the weeds, but just initial impressions. What concerns you when you're thinking about using both ideas, strategies? So this is kind of framing what we're hoping to have discussion with you guys about. We know that there are others that are using respecting choices and something else, like Stephanie just presented with Vital Talk. I know several programs that have very successfully integrated Angelo Volandi's videos into the facilitated conversation. So it's along that theme that we're really trying to say, how can we collaborate so you guys have broader choices without recreating the wheel, and we don't feel like it's the right thing to do to continue creating new when others are doing it so well. You guys all know we don't have a really solid public-facing arm of respecting choices. That's never been one of our goals because others are doing it really well. So that's the goal of our discussion with you. So let's start with the first question. What do you see as synergistic? What excites you about the opportunity for both? Julie? Actually, I am going to run around to you guys so I don't have to repeat, because you might have a comment longer than I can remember.
Was that directed specifically at me? Stephanie knows me. Except for that, it's also accurate. So in the midst of trying to pick products for all of these in my project, as you know, and so filling the gap between facilitated conversations and when the patient sort of and our first contact with the patient is exciting to me. So and as you said, and I hadn't put it into my own words before, that it can serve two purposes. The first being it might be all a patient needs, which automatically allows us to show results without having to use any of our staff time and resources. And then the second is as a primer for the rest of the conversation once the patient shows up in a facilitation space.
Thank you. Rebecca, will you speak to the, if you're using Prepare, does that use any staff time? Or can it be done completely outside?
Yeah, so the one thing I will say is that even if, people complete Prepare or have an advanced directive, I still think at some point it has to come back to the clinician. So somebody still needs to review it and have a conversation. So I would never want to say it's 100% out. I do think for some, and not all people, I do think for some that's really all that they do need. As we've shown in our trials, and again, even people with low health literacy can sort of engage.
Nice.
And some people will have additional questions. Some people will need additional support to go the extra step.
And I completely agree with you, Julie. I think this has potential to shorten a facilitated conversation. So I heard somebody saying their advanced steps conversation takes 30 minutes. Sometimes it's 45. And if this reduces that time, more conversations can be had if it's a resource standpoint. Okay, what other synergies?
So we contracted with Prepare for Your Care so that we could more specifically track the use. And I think our initial hope was that we want the individuals engaging in advanced care planning to be able to have something right there for them whenever they feel ready. So if it's they're able to come in and go to a group conversation, great. But if they're at home thinking, you know what, I've got an hour, I really want to just be able to make it easy for them to do the right thing. So we were seeing it as just another mode of engagement. And So again, I do see it as filling in some of those gaps between readiness and then availability of a facilitator. And also we know, just thinking about our younger individuals that might engage in advanced care planning, they may not want face-to-face. They may feel more comfortable at least initiating something online.
Right.
So that, having that technology available, which is more comfortable for some populations.
Nice. And
was
what gets more
available.
person-centered and family-oriented than
Yep.
meeting the person where they're at and what
Exactly.
needs they have at the time, right?
And I think also the fact that it is soup to nuts, so that, but they can come in and out of it. So they may not be ready on a Tuesday, in October to complete the document, but the document is there when they are ready, and all of their information. The ease of it, I think, is also very synergistic, because I think once people have had a first steps conversation, it's easier to do their documentation because they have those
Nice.
goals and values top of
Nice.
mind.
So I hadn't thought about it from the reverse. I had thought about prepare first and then a facilitated conversation, but you may be in a facilitated conversation. They're not ready to either move forward with it or complete anything, and this could be even a follow-up or interim component. That might raise some concerns with any misalignment. I'm not sure. I haven't looked at it close. We haven't done that assessment, but we can flag that next. Oh, I'm gonna run.
So I keep coming back to the idea from the very beginning of honoring choices, which was planning is a process, directives are documents. Documents aren't available at the time of decision making, 3 a.m. in the morning. There's no documents anywhere. But there's a human person that is going to be your advocate, your agent, your proxy. So what I see from here is whether you use prepare or an honoring choices, respecting choices conversation, the ball is rolling. It's starting. That planning process, the awareness that I'm going to start talking about this with somebody. I think in those two models, you get that goal. And I know at this conference we're talking a lot about where do you put the document? How are you going to retrieve it? And I still really love collecting toolkits and documents and DPOAs and things and pulse forms that are necessary. But I keep on going back to the idea of I can do this to the end of the earth, and I do palliative medicine. I can do this to the end of the earth. They might not have that document at 4 a.m. in the ER or in the nursing home, and they get confused and then they need to go to the hospital or whatever. It still goes back to the person that is their advocate and that decision making. So I have to step back and just say it's still about the planning.
Nice. So the theme I heard there is they're very synergistic in elevating the importance of the role of the agent, selection and preparation. Nice. Mike, over to Kelly.
So I have a question about the translated versions. Is English on one page and the foreign language on another? Is it just in the same format so that a English-speaking medical team can interpret what this Chinese document says, and knowing that an advanced directive is, the emergent part is only who's my person, and
Right.
I can maybe say that name and dial that phone number. How does
Yeah.
that look?
That has been such a learning experience. So I'll tell you, we naively, whatever it was, 15 years ago, translated our first form in Spanish, and realized very quickly, well, if the provider doesn't speak Spanish, that doesn't help anyone, right? So then we've spent a long time sort of talking to patients and their families about what they want, and we actually have 2 versions. We have one version where on one side is the, say, Spanish with the English underneath it, and on the other side is just Spanish. Because if you get an older adult who has low health literacy and they see a bunch of words on text, they're done. That's it. But you want it, it has to be lined up so you can tell that we're not trying to pull the wool over anybody's eyes. The other thing is we had a lot of patients who their bilingual children sort of wanted this, and so there was a lot of mistrust, and again, that's why we had to really make sure that everything was completely aligned. Many of you know the Chinese American Coalition for Compassionate Care. We've done this with Chinese as well. And even though we make that version available, they actually only hand out the version that has the Chinese characters and the English underneath. So I think it depends upon what the institution wants to use, but we have both kinds for that very reason.
Rebecca, hi.
Hi.
I love the work you do. I think this is awesome. But I hear on the radio that the threat to humanity is climate change, nuclear war, and artificial intelligence. And this is sort of artificial intelligence, and shame on us for doing a poor job of communicating. But it seems to me that this will sort of take people off the hook. You know, it's like, oh, we don't have to do communication skills because we have this tool now to do this. And maybe that's the way it should be. But we have to think carefully about how we combine this together so that we don't lose those skills.
Absolutely.
Right.
And I think, you know, one thing I will say as a primary care provider, I'm happy for anything that gets me off the hook on anything. And it's not that I don't want to, it's just that when I get alert, like the alert fatigue is unbelievable. Every week I come in and I have a stack of papers this big that need my attention and signatures, and I open up a patient's chart and there are 40 things that I have to check off. And now that we've created these wonderful electronic health records where I have to do 40 clicks to order a flu shot, it's just overwhelming. And so it's like, yes, and like, I totally agree with you. And like I said, that piece where it comes back to a clinician, you still can't get out of the conversation at some point. Though I will say I've had my colleagues say like, oh my goodness, I knew I had to have this conversation. I knew I didn't have time. And then this person came in with a summary of their wishes and basically just said, okay, so I did this thing and this is what I want and whatever. And it was like done for me, you know, in some way, right? They still had questions and they still had to put in the medical record, but I'm hoping. Yeah.
And I want to validate that concern, because that's a concern I've heard from others and us as well. In today's tight economy and speed of delivery of healthcare services, people tend to want to be able to push the easy button. That doesn't meet everybody's needs, right?
Right.
And so that is a fear that this could be seen as just pressing the easy button. And I think this morning, we talked about you haven't had the opportunity doing this long enough to look at the efficacy of the document and using it to guide clinical care and meeting the ultimate desired outcome of knowing and honoring and having concordance of care. And so there's still, I think, work to be done, because we know of programs across the country that have been doing pieces of this work and they have not met their desired outcomes. So that's why we're really trying to think about this in more of a collaborative way, recognizing that together we think we're better. But it is the fear of being able to say, just let's hit the easy button. Thanks.
And I think just one thing to say about that as well that I also worry about, because I think this is happening in the context of what is good is that increased attention to advanced care planning by health systems, this idea that you can bill, and things like in California, there's something called the prime metric for sort of public hospitals, that basically this was one of their, like for UCSF, this was a prime metric. So in terms of some of the unintended consequences, what that winds up happening is, to meet the metric, instead of attaining quality, we try to figure out the lowest possible denominator to click the button. And what I don't want to have happen is like, oh, patient did prepare, click, we're done. That's what I don't want to have happen.
I was just going to say, as a grassroots effort, one of the things I came here looking for was how can we reduce the lag time between making an invitation for somebody to come for a conversation and when they actually call. I just had a client that waited 2.5 years, and that makes it a little difficult. And I have another facilitator that's working a little more closely with the hospital system that has a tremendous number of no-show people. So these become problems when you're trying to use volunteers to do some of this work to supplement what's going on in the hospital.
Perfect, thank you. So you're moving us into more of the how. I think we could use this to help solve some of those problems. Before we go to the how, I want to see if there's any other, we moved from what's synergistic, addressed a couple of the concerns. Any other concerns? Yes.
I just had a concern thinking, I really appreciate, I was looking online at the, when you talked about the health literacy and the ease of completing that form for giving to patients to be able to do on their own. I'm just wondering about the different language that's used from, like we use Honoring Choices Minnesota, which kind of follows the model of Respecting Choices, or we use language like healthcare agent or those kinds of things, whereas this says medical decision maker. So there's some differences, and I'm just wondering about the confusion of having multiple forms to give to patients, that they see different wording and the messaging is a little bit different.
So great, thank you. That was one of the questions we had is, does this language, to some extent misalignment, is that a concern for folks? Bud and I have talked about, would there be a case to be made for an RC prepare? We know that it aligns exactly with RC language, or is that too narrow thinking? Should we be thinking broader than that? So for example, I'm having a conversation in January at the Conversation Project. They use way more end-of-life language than we do. We've pretty much removed end-of-life language because decision makers make decisions multiple times, usually when somebody's unresponsive on a ventilator or what have you. And so we're talking about that language alignment. And so maybe it's bigger than that. Maybe it's all of us coming together to say, can we standardize language? And then I heard Rebecca say they couldn't get consensus on a definition of advanced care planning. And I thought, is that a mountain we should be climbing? But maybe it is.
I mean, I sort of think that it is. And especially if we got, people and their families to help us get out of our clinical mindset. The other thing is that a lot of these terms came from the legal probate codes that are written into state law. Mm-hmm. That doesn't mean that we don't walk around saying, here's my agent. Right. And we've come up with words like surrogate. I would say we came up with medical decision maker only because we did like 14 different focus groups, and that like we didn't come up with that word. It wouldn't have been the word that I would have chosen because we had healthcare agent to start out with. But I agree, it winds up becoming confusing. I will say even in my own institution, when we went to the cancer center, there's like 5 different forms that call it 5 different things in one clinic. So I can only imagine what's sort of out there across the country.
And I know CAPC's been doing a lot of studying on language. John presented on the AARP and Optum work on language. Has been all public-facing feedback. So perhaps a goal should be a national advanced care planning glossary.
Why not?
That is approved by the country,
Yeah.
Not just the health systems.
Let's do it.
Okay, any other concerns?
So this sort of bridges concerns and strategies, so put it where you need to. For me, the missing piece, if we were to do this in my organization, would be the integration with the EMR. And so, this may not be appropriate for this setting, but I know you're free and available online, but is there an additional offering that would allow us to integrate it and the analytics to track?
Mm-hmm. So thank you for that question. I think I often get asked, how can we make this free to the public? And the way that we are able to make it free to the public is a lot of, I would say, blood, sweat, and tears on our part to write grants. We don't have very many donations, but we do have some licensing. So we have some licensing, say with Dartmouth-Hitchcock, where what we can do things like have links that are very specific to that particular institution. Do you guys mind if I talk about? Okay. So for example, Dartmouth-Hitchcock wanted to do a campaign with the community as well as with their staff. We were able to create links that were specific for those groups, sort of in a way, kind of, we call it white labeling or whatever for Dartmouth-Hitchcock. And then we could also track people's use of Prepare that way. So that is not integration, but it does help you to sort of see its data in terms of who's going to the site and is there uptake and things like that. We are not a company. I'm at the University of California, San Francisco. I am not a vendor, and I am not a software engineer. Mm-hmm. And so just like you were talking about how you sort of staying in your lane in terms of the things that you know what you to do, I'm sort of staying where we have to stay in our lane because we don't do that integration. Mm-hmm. Now that being said, there are many companies out there that we are speaking with. Some of them were probably here over the last couple of days, which have sort of figured out how to get over the firewall and to have many sort of, can be like a repository for many of these types of things, whether it's diabetes or advanced care planning, to do that integration that we can't. I don't necessarily feel comfortable naming those things, but they're out there and we're starting to talk with them. That is an eventual hope.
Yep.
For us, it will take an infusion of some funds to get us to that point, and we keep looking.
So I'll comment to that because I can speak to some, because this has been one of my high priorities since becoming Deputy Executive Director. And we're in collaboration conversations with both Vinca, Wiser Care, Vital Decisions, who's here, several others. And what I'm coming to understand in seeing the 30,000-foot big picture of this is that there are many of us in this space, but very few of us that are actually in direct competition with each other. But what we are in is competition for the small amount of funds out there to best meet individuals' needs, right? And so we even talked about, do we need a clearinghouse? Should Respecting Choices become a clearinghouse where all of these programs are located, or another entity, not necessarily us, where all of these programs are located, so when you buy something, you pick and choose what best meets your need, rather than paying us and paying them and paying Vinca and so forth. Is that, I'm seeing heads nodding, does that resonate with you guys? Or you're thinking, we're a capitalist country and that would reduce some of the benefits of competition? I don't know, it's an intriguing idea. Brian, let me bring can you speak? You've been dealing with this with CAPC forever.
Well, I don't want to speak to the data thing, but I would like to add a concern or strategy, and that is there a short list of contraindications that patients or families would have that would make the prepare, kind of do-it-yourself model less appropriate than a facilitated conversation? Like they're on a transplant list, or they have a device implanted that is life-sustaining, or have 3 different progressive diseases with complicated treatment regimens and things like that. So
Yeah, that's a great question, and actually, I don't know. I mean, in the, close to 1,500 patients that we've tested this in, it's been in primary care. The only patients who the primary care providers have said don't approach were people who were actively psychotic. But there were no reasons, that actively psychotic and people who have dementia.
what about illiteracy, like significant?
Yeah, we had about, in our Spanish-speaking population, there was probably, I think it was 11% of people who were completely illiterate, and 60% of them had limited health literacy. So that's not, actually, it's a reason to send them to prepare, because we've written everything, and again, tried to set it up for even if people don't read, they can watch the movie versions and things like that. So I would say that the literacy piece is not a contraindication. I would also say, as a palliative care physician, working with some of my colleagues who feel that there's conditions that make palliative care a contraindication, like they're on the transplant list, like they just had surgery and it hasn't been 30 days yet. I might not think it's a contraindication, but there might be healthcare leaders out there that do. I just haven't seen it in our primary care
Great,
group.
thanks. We only have a couple minutes left, and so I'd like to open it up for any new thoughts that we haven't talked about that you think Rebecca and I should know in whatever area, or questions that you have that you didn't get to ask.
I just have one question because
Yeah,
I'm fairly new to learning about advanced care planning and in knowing what's out there across the nation. And so I just heard somebody say in contracting with Prepare, is your material free? Is there something that does cost to partner with you? And so could you explain that just a little bit more so I understand that?
Yes. So if you go to the prepareforyourcare.org website right now, anything that you find there is free. So if you wanted to do a research study and you have grant funding, then we ask for a license. Those are ways that we keep ourselves sustainable. if there's a health system that would like to white label our materials and have it be X health system prepare, we white label for that. There are many institutions that would like to put their logo on our advanced directives so it looks like it comes from them. Then we do licenses for that. We do licenses if people want to roll out a program and actually track use of prepare. But if you today want to go and hand somebody a pamphlet or advanced directive, you can just download them off the.
And as you spoke about, that makes a tough business case to be sustainable. But it helps, right? To answer your question related to respecting choices, so we have patient educational material as well as our new decision aids that can all be licensed, so you can put your logo on them. We also allow customization as long as we approve it. But being a not-for-profit, we would not have stayed in business all this time if we didn't charge for our services. It's an unfortunate, but we'd be gone, I think, if we hadn't done it that way. So it's just the different business models that are just so challenging in this space because you just want to do the right thing and you don't want to charge anybody for it. So it's a great question. Thank you. Alan?
Thank you. I just wanted to, I guess this is along the lines of synergies, just to offer one thought about what sounds often like a dichotomization of documentation and conversation, or documentation and a reflection process. Of course, it's valuable, I think, to have documents in the medical record so they're there in case. But the other reason I think for doing documentation is that doing documentation helps people think. Mm-hmm. And it's different in a way, even from thinking in conversation. And so I'm with Vital Decisions. We do telephonic advanced care planning facilitation across the country. And so our specialists have these conversations over the phone, and we then invite documentation and so on. And part of the reason to document is to inform people's doctors and loved ones about what we want. But part of it is, well, if I have to answer these questions in writing, that's different from if I'm just thinking about these questions.
Right. Some folks need different things. Are we out of time, or do I have time for one more?
We're out of time now.
Oh, sorry. Why don't you comment, Rebecca, and we'll close.
Well, I guess it allows me to come back to actually comment on something that I wanted to say for Stephanie, because I was going to say you're singing my song about the conversations. I'm on my soapbox all the time with trainees that say, if you just write full code, that means nothing to me. It means nothing to your other colleagues. It means nothing to family members in the middle of the night in the ICU if you don't document that discussion. And one of the new things in EPIC coming out are these things called bookends for advanced care planning. I don't know if you know that, but where you can, this is at least in EPIC, doesn't matter if you're using a smart phrase, it doesn't matter if you're using a templated note. Whatever you want, you can be in primary care, you can be in palliative care, you can be in the ICU, and if you use these bookends, it will pull it into the Advanced Care Planning Navigator. So that is supposed to be launched in this next version, but that's a great way to get those conversations where they need to be.
Thank you so much. Can we give a round of applause for both of our presenters? Thank you.